Hey friends, this episode of The Fellow on Call is not meant to be used for medical advice and is intended for educational purposes only. Patient information has been modified to ensure privacy. The views expressed in this episode do not necessarily reflect the views of our employers. Enjoy!
Welcome to another episode of The Fellow on Call, the Hem-Onc podcast. We're coming at you from Merlot University Medical Center. I'm Ronak.
I'm Vivek.
And I'm Dan.
And in today's episode, we continue on our discussion about AML and focusing on consolidation and maintenance therapy. This is the second episode of our consolidation and maintenance therapy sub-series of a disease type. And so we're excited to pick up where we left off last time. If you haven't listened to part one, we highly recommend that you do so. We stopped at our discussion about high dose versus lower dose cytarabine for the purposes of consolidation. And I'm sure you're all on the edge of your seats to pick up on this conversation today.
I know I am.
So let's not keep you waiting, Dan. Let's not keep our listeners waiting. Let's go ahead and roll right into that show. So, guys, I think we're going to pick up today where we left off last week. And so, Vivek, do you want to quickly remind our listeners about our patient and where we're at in terms of her disease management?
Yeah, and just very briefly, my house is fine. The gas leak, actually, we did not have a leak in our house. It's probably one of our neighbors, which is a little bit terrifying. But anyway, just wanted to recap from last week's episode. Check out the intro for that. It's not in our show notes. So back to this case. So remember, just to remind all our listeners, we had a 60-year-old female. She had treatment-related AML with that KMT2A rearrangement in 11q23. She ended up having intermediate risk AML. She had gotten CPX-351 or Vyxeos induction, and then we were searching for a transplant donor. She didn't have a matched sibling donor. She didn't have a good suitable relative that could donate for her. So undergoing that search, and then we had started her on consolidation chemotherapy with what we call HiDAC or high-dose Ara-C, high-dose cytarabine at 1.5 grams per meter squared on days 1, 2, and 3. So to recap very briefly of what we talked about last week, we had discussed that no maintenance therapy after remission is a no-go. 100% of patients will relapse. So you got to do something. Then we discussed in 1994, this HiDAC consolidation at 3 grams per meter squared every 12 hours, given on days 1, 3, and 5, repeated monthly. And in that study for 4 cycles, followed by additional chemotherapy maintenance for 4 more cycles, was considered standard of care. Then Dan walked us through further history that said, hey, actually, HiDAC, that high-dose cytarabine for 3 cycles is all we need. After that, we discussed, when Ronak went through some of the data, that, hey, look, we can actually do this on days 1, 2, and 3 and use GCSF support. That'll reduce some of this febrile neutropenia. It'll reduce hospitalizations, improve some of those important quality of life outcomes without compromising relapse and things like that. And then the last thing we talked about, the lower dose of cytarabine, and I think that's really important. So Dan, can you recap that? And then we'll get back to our case.
There's this high dose cytarabine and then intermediate dose cytarabine. And we're broadly defining that as anything above 2 grams per meter squared for high dose and between 1 and 2 for intermediate dose. But in practice, we're thinking about, do we want to give a patient 3 grams per meter squared or 1.5 grams per meter squared? Unfortunately, despite the fact that 10 randomized phase 3 trials were performed between 1994 and 2016, we didn't have any that directly compared these 2 doses. And there was an attempt at doing a network meta-analysis with this very fancy statistical magic that was able to try and derive a comparison between these 2. But ultimately, it's really hard to know exactly what degree of validity we can draw from those conclusions. And we're still thinking that patients above the age of 60 probably should be treated with 1.5 grams per meter squared dosing because we know how important consolidation is. And we also know that folks over that age have a really hard time tolerating 3 grams per meter squared. And so in the interest of providing some degree of consolidation therapy that we think is probably beneficial and at least has significantly lower toxicity, that's often what we'll reach for. And so for folks with favorable risk cytogenetics, that was a conclusion they drew from this meta-analysis. It seemed like there was a bigger degree of benefit for using higher dose. So for folks who consolidation may be the final phase of their treatment journey, we're still thinking about using that higher dose cytarabine and certainly for younger, fitter patients. But that's kind of the story from what we're thinking about these 2 doses.
All right, great. So now we're caught up with our patient case. So she's at the age of 60. And like Dan had mentioned, a lot of these patients were not doing that 3 grams per meter squared dosing. So she got consolidation therapy with high-dose cytarabine at 1.5 grams per meter squared on days 1, 2, and 3, that consecutive dosing with GCSF support. She did not require admissions for febrile neutropenia, and a matched unrelated donor was found. She had another consolidation cycle as sort of a bridge and then proceeded to an allo transplant. So we always talk about moving to allogeneic transplant as soon as possible for these patients who have intermediate or adverse risk disease. But Rona, can you tell us, is there any data on the number of cycles of consolidation therapy? We talked about how there was 4 cycles, and then the stuff that Dan talked about in her historical interlude in the last episode, it was 3 cycles, was sort of arbitrarily chosen. So what about the number of cycles? Has anybody looked at that?
Yeah, so unfortunately, there's just no good evidence on the optimal number of cycles for these patients. And so we knew from 1994 that only 50% of patients tolerated the high dose, the high-DAC cytarabine at 3 grams per meter squared every 12 hours on days 1, 3, and 5 for 4 cycles. So we often proceed with 3 cycles of therapy based on the other trials that we had discussed. So there was this intergroup US trial that we will discuss in more detail soon, but essentially this trial compared 1 cycle of HiDAC versus autologous transplant in consolidation. What they found was that 1 cycle of therapy was effective, so there was an argument for fewer cycles of consolidation, but this question was never really studied to date in a prospective fashion. And this is the thing that I find really hard about AML, is that there's so many of these trials and each of them uses a slightly different induction strategy. Thinking back to even our induction series where we talked about the differences in approach between the US and Europe. In Europe, they're using double inductions. Like, how does that incorporate into the mix of all of this? So this really makes interpretation of the number of cycles in consolidation sort of challenging, and there really is no great data on de-escalation approaches, as we're sort of alluding to here. So with that in mind, what if we shift gears a little bit and talk a little bit more about allogeneic transplant? We've sort of been dancing around this topic for quite some time already in the last couple of episodes. I think it's time to hit the nail on the head. And so we discussed in our induction episode that for favorable risk patients, we prefer induction 7+3 GO. And recall this was based on a meta-analysis that we'll link again in our show notes this time for a refresher. And we discuss how these patients should get HiDAC consolidation for 3 cycles, and there may be a greater benefit for the 3 grams per meter squared dosing in this population, but we don't proceed to transplant in these patients with favorable risk cytogenetics. But for the intermediate and adverse risk patients, we do proceed with an allogeneic transplant and the use of consolidation HiDAC as a bridge. And I want to emphasize it's an allogeneic transplant because, believe it or not, test writers like the difference between allo and auto, and this may or may not come up on a test in the future. And so we will get into the role of MRD testing in favorable risk patients to determine whether these patients may benefit from transplant in a future episode. But for now, what are some of the basic things that we need to know about allogeneic transplants?
AML was the prototypical disease to cure with allogeneic stem cell transplant. For many years, treatment-related mortality was very high due to severe infections or high rates of GVHD. Both of these things were a problem. Patients really only proceeded to allogeneic transplant if they could tolerate ablative conditioning chemotherapy and had matched sibling donors due to these issues. And so it was not as widely available a therapy as it is today. Remember that in an ablative transplant, conditioning chemotherapy is used to completely get rid of the native marrow so that the new non-self donor stem cells can engraft and have optimal hematopoietic stem cell function. These allogeneic stem cells will then lead to a therapeutic graft versus leukemia effect. Remember, the graft is a new immune system for the patient, and the idea is that it will see those leukemic cells, any residual leukemic cells that are there after conditioning chemotherapy, as non-self and will attack them. The chemotherapy that we use for this ablation of the marrow is far more toxic than the conditioning that we use for autologous stem cell transplant, where you're really just giving a really intense dose of chemotherapy that's targeted at the tumor cells themselves and not with the express purpose of ablating the marrow. Over time, there are newer reduced intensity conditioning regimens that were developed. Those will be noted as RIC, or for reduced intensity conditioning, RIC, as opposed to myeloablative conditioning, which is noted as MAC for myeloablative conditioning. The reduced intensity conditioning regimens allowed for transplant to be offered to more patients in general, older patients, a little bit more frail patients. At the same time, improvements in management of immunosuppression and sort of how we strike that balance between allowing graft versus leukemia and suppressing GVHD allowed for transplantation with matched unrelated donors. And so as another thing that really broadened the reach of transplant as a therapeutic option. And for many patients with AML, allogeneic transplant represents the only treatment modality that could cure their disease. And so really important that we're trying to broaden who we can give this therapy to.
Yeah, Dan, I think it's really important to define some of those more fundamental concepts. A few things I want to add on to that. You'll see peripheral blood stem cell transplant, sometimes notated PBSCT, versus a bone marrow donation of transplant. Sometimes you'll see cord blood. You probably are wondering what's the difference between all these and why are we seeing so many peripheral blood stem cell transplants nowadays? The reason why, if you collect the stem cells from the peripheral blood as opposed to the marrow, you're collecting more lymphocytes, and that's actually allowing you to boost your graft versus leukemic effect. The second thing is these peripheral blood stem cell collections have an improved engraftment. So if you donate the stem cells, they have a higher chance of engrafting earlier. So you have better engraftment and better graft versus leukemic effect. So that all sounds great, right? The problem is you also have more GVHD. So it's one of those things, again, as we had better immune suppression, we were able to do these peripheral blood stem cell transplants, better engraftment, which is why you see it so common nowadays, better graft versus leukemia effect, with the downside of seeing more graft versus host disease. Those are a couple of more things I wanted to add on to this. And it's really important that we have these RIC conditioning regimens, these reduced intensity conditioning. And you'll see in the CIBMTR, which is the registry in America, and the EBMT, which is all the bone marrow transplant registries in Europe, that these RIC patients tend to have more relapse. They tend not to do as well as patients who got myeloablative conditioning. This is changing as data evolves, as we get some more updated analyses, but these are important things to know. And now we've expanded this transplant indications. You can have patients in their 70s who are getting an allo transplant for curative intent in AML, which is pretty spectacular.
The whole process of allogeneic transplant, from donor search, conditioning therapy, management of acute complications, balancing GVHD and graft versus leukemia effect, is so complex, as we're alluding to. Maybe let's take a step back and focus on the broad data on efficacy. Why do we proceed with allogeneic transplants? And to take that one step further, have we ever looked into autologous transplants in consolidation as opposed to just reaching for the allos?
Historically, outcomes for AML patients were very poor without allogeneic transplant, in younger patients anyway. We talked about that in our last episode. One of the pivotal studies looking at consolidative autologous transplant versus chemotherapy alone was published in New England Journal of Medicine back in 1998, so had this data on hand for a while. Patients who were in remission after induction chemotherapy were randomized to one cycle of HiDAC versus autologous stem cell transplant with busulfan and cyclophosphamide conditioning if a matched sibling donor was not available. They saw no difference in survival between these two groups. It's important to note that relapse happened in about 60% of patients who had HiDAC and were then salvaged with either auto or allo transplant. Treatment-related mortality was about 20% in patients who had received an allogeneic transplant and 14% in patients who got autologous stem cell transplant, which just highlights how much higher transplant-related mortality was in that era compared to what we see nowadays. This showed that consolidation chemotherapy seemed to be just as effective as autologous stem cell transplant. Ultimately, the role of autologous transplant was abandoned and has not really been reevaluated in the modern era, but it would likely only offer a modest benefit over consolidation HiDAC chemotherapy. So it really we don't see a big role for it in the modern treatment of AML. And so based on that, it seems reasonable that we've moved away from auto transplant consolidation, but how did it come about that we don't transplant favorable risk patients?
So one of the best studies that showed a benefit of transplant in intermediate to adverse risk patients, but not favorable risk patients, was actually a meta-analysis as well, and this was published in JAMA in 2009. So the study included 24 trials and over 6,000 patients, and about 3,600 patients also had cytogenetic risk information. allogeneic transplant had improved relapse-free survival and overall survival in patients in that intermediate group and the adverse risk cytogenetic group. And allotransplant was not associated with improved survival compared to other consolidative approaches for the favorable risk group. And so this was the first sort of indication that perhaps there was this difference in how we can approach patients with favorable risk cytogenetics. There was another study from the European Bone Marrow Registry that was published in JCO in 2008, and that showed no difference between auto-transplant consolidation versus allo-transplant consolidation in patients with favorable risk AML transplant in their first CR. Both of these studies serve as the foundation for why patients with favorable risk disease are treated with consolidative HiDAC as opposed to allotransplant and consolidation. So this is so important if you take away nothing else from this conversation. Understanding what patients' cytogenetic markers are is fundamental for helping us stratify how we decide what happens to patients after that initial consolidation therapy. Patients with favorable risk cytogenetics in general are not going to proceed with that allogeneic transplant. Of course, there's exceptions to that, I'm sure. But in general, they're not going to proceed with an allo. This is such critical information for us to know.
It's important that we also place in context here that this role of a consolidative autologous transplant was abandoned because of the study that Dan had mentioned in 1998 that showed one cycle of HiDAC, only one cycle of HiDAC, had the same outcomes as consolidative autotransplant. Obviously, consolidative autotransplant had higher toxicities and that treatment-related mortality back then of 14%. So that really showed us that HiDAC consolidation is important and only one cycle, but that relapse rate that Dan had mentioned of 60% is quite high. And this is why we don't stop at one cycle of HiDAC. Even though this one study that showed that comparison showed that, we had all of the other studies that we've talked about in the last episode and part of this episode in consolidation HiDAC approaches that have used 3 to 4 cycles. So this is important as you think about other studies. Think about that Vixio study that we've talked about for that secondary AML patient that had, it was Vixios versus 7+3. What did they get in consolidation? 5+2. Is that appropriate when we had just told you that HiDAC consolidation for 3 cycles had been standard for so many trials? We were talking about, oh, well, I wish they had looked at de-escalation strategies, but none of those multi-agent chemotherapy approaches had beaten it and had more toxicity. So it makes you wonder, why was that the case if nobody was doing that as standard of care, which is a problem with that clinical trial? Another trial that's a problem that we're going to talk about in a later episode as we talk about maintenance strategies in AML with things like oral azacitidine and the FLT3 inhibitors is the oral azacitidine maintenance study. 20% of patients on that trial in the control arm did not receive any consolidation. And we said 100% of patients relapsed in that case. So again, we'll be talking about this as we move forward through this series, but all of these are really important things to kind of tuck away and to really review all of the data that we're going to present very clearly in our show notes.
So before we close this episode, let's take a patient case who had an NPM1 mutated AML and undergoes 7+3 GO induction chemotherapy, because remember, NPM1 is one of those favorable risk cytogenetic markers. And they have a morphologic CR on the bone marrow biopsy, and they are favorable risk, so we typically defer transplant. But in the current era, how might MRD testing change management in this case? And listeners, you'll remember we've talked about MRD in other disease types before. We're building on that conversation, integrating MRD testing into AML management. So again, how might we integrate MRD testing, and how would this change our approach to this patient with favorable risk cytogenetics?
The important thing to know here is that this is a truly evolving space in AML. Right now, there are many trials ongoing to help address how we need to use MRD. As Ronak had mentioned, knowing that somebody has a cytogenetic favorable risk profile is critically important, right? You may not take them to an allo transplant that has high treatment-related mortality, morbidity from GVHD, all of these long-term immunosuppression, all of these things that we really try to avoid. For this patient, per the European Leukemia Network 2022, the presence of NPM1 mutation without FLT3-ITD is considered favorable risk, and if there is a code mutation with 3-ITD, the patient's considered intermediate risk. So then how do we apply MRD testing to these patients? So remember, molecular studies can change your risk stratification from that initial group, even if you have favorable risk cytogenetics. So how do we think about this? Well, there were 2 prospective randomized trials run in the UK called AML 17 and AML 19. Don't worry about the inclusion criteria. Just know they got intensive induction chemotherapy. In both of these studies, NPM1 status and FLT3 status were known, and they looked at PCR, meaning they looked at the molecular test for NPM1 after induction chemotherapy treatment in the peripheral blood and the bone marrow, and said, if we could find it, you're MRD positive. If we can't find it on PCR-based testing, you're MRD negative. So this is at the level of 10 to the negative 6. So really, it's like 1 in a million. If there's 1 in a million left, we could detect it. It's important to know this was a European study, so these patients got double induction, as we've talked about in previous episodes. So they got 2 inductions, and then they had MRD testing at the end of their second induction. And what they found was that for patients who are MRD negative, so they couldn't detect the NPM1, so forget about the FLT3, nobody's actually testing for that in this study, but if you're MRD negative for NPM1, for those who are NPM1 mutated, there was no benefit for an allotransplant. The 3-year overall survival for allotransplant was 79%, compared to 82% if they got HiDAC consolidation. No benefit for transplant. But if they were MRD positive, so meaning at the end of these double inductions, the end of induction, you looked at the peripheral blood and said, can I find NPM1 PCR-based testing? And if you were MRD positive, meaning it was positive, you could find it. There was a significant OS benefit for allotransplant compared to consolidation HiDAC, with a 3-year overall survival of 61% compared to only 24%. So it's a massive difference in overall survival. So what this showed us is that we should incorporate MRD testing for NPM1 mutated patients. And this idea of MRD, and what about MRD flow? What about 10 to the minus 4, 10 to the minus 5, all these things we've talking about? Can we spare transplant in some of these patients? And that's critical. That's going to be really important for the field. And one very interesting thing is that some of these patients, it's common actually for you to have an NPM1 mutation with a FLT3 ITD mutation. In our induction episodes, we talked about the Ratify trial with 7 plus 3 plus midostaurin in induction. And we also mentioned the Quantum First study, which is the same induction except with quizartinib. We very briefly mentioned that. And that was standard of care. But when these studies were running, they didn't have FLT3 inhibitors in induction, yet they still had those impressive outcomes, even if they had FLT3 ITD mutation, without a FLT3 inhibitor induction, with those crazy survival results with no allotransplant if they're MRD negative, if their NPM1 was MRD negative. So it makes you wonder, if you had patients who had FLT3 ITD and they were MRD negative, do they need a transplant? It really brings that question into your head. And we do, from the Ratify trial, the 7 plus 3 midostaurin trial, patients who had FLT3 ITD mutation and co-mutation of NPM1 did not benefit from allotransplant in first remission in that study. So this really just adds to the idea that MRD is actually super important, particularly for favorable risk patients. What is this going to mean for the intermediate risk and adverse risk patients? We don't know yet, right? That's what we need to validate before we just apply this in prime time.
So that was a really good discussion. I think we talked a little bit about duration of consolidation therapy here, how there's not a great base of evidence for how many cycles of consolidation to offer, but we settled kind of on 3, and that there's no real role for autologous transplant in consolidation therapy. We talked about how the history of stem cell transplant saw us gradually expanding the number of patients we've been offering it to, and just how important it is in terms of survival benefit for patients as a curative option. But that there's also this subset of folks with favorable risk disease who may not need it. And wrapped it up with the discussion that there's a lot more coming in this space in terms of who can we get away with consolidation therapy alone and maybe some targeted maintenance therapies as opposed to proceeding to allogeneic stem cell transplant, understanding that although we've made a lot of improvements, there's still a great amount of treatment-related mortality from allogeneic stem cell transplant. It's an exciting field, AML, because there is so much happening and so much improvement being made right now.
Great summary, Dan, and so well said. So guys, I think that wraps up a fantastic discussion over 2 weeks on AML consolidation and maintenance. So until next time, we'll see you all later.
See you later.
Peace.